I am in Vancouver instead of Kansas City. The sun is not up yet, but I am because this is an exciting topic. Um, so I have no financial disclosures. I work at an academic children's hospital. I am not a molecular person. I am a clinical child neurologist with a background in movement disorders and systems neuroscience. When I think about things clinically, I have to lump things together to try to understand what's going on instead of splitting things down to molecules and receptors. So, and as part of my training, I was trained to think about how symptoms and problems related to each other. And the field of movement disorders neurology is about recognizing patterns of abnormal movements and then understanding and appreciating the symptoms that go with those abnormal movements. So what we're going to spend the bulk of the time talking about today is the autonomic nervous system. So the autonomic nervous system is responsible for the automatic functions of the human existence. Things like heart rate, intestinal motility, sweating, arousal state, sleep-wake cycles, and response to pain. And the autonomic nervous system has three branches. The largest branch is what's called the enteric nervous system. And the enteric nervous system stretches from the top of the esophagus all the way down to the bottom of the rectum. And it is responsible for moving things through your intestinal tract. And when your autonomic system does not function properly, you end up with GI problems in terms of reflux and constipation and problems moving food and fluids through your intestinal tract. There's also the sympathetic nervous system, the fight, flight, or freeze response, which we'll talk about in great detail. And its polar opposite, the parasympathetic nervous system, which is the rest and digest system. When we look at the autonomic nervous system, it is an incredibly complex system. It involves everything from the eye all the way down to the pelvis. And as you can see here on the left side of the screen is the parasympathetic system, and you see everything listed there in blue. And the point of the parasympathetic nervous system is to calm the system down. Whereas on the right side, the sympathetic nervous system in red excites everything. And these are supposed to exist in an equal balance. And that's what really homeostasis, or just living life and not having any symptoms, is a balance of your parasympathetic and sympathetic nervous systems making your body function properly. The autonomic nervous system is not autonomous. It is under control of the brain. And the brain regions that control the autonomic nervous system, one of the largest, one of the most important, but not structurally the largest, is the hypothalamus. It is really control central for autonomic control. It helps to regulate hunger and thirst, sleep-wake cycles, temperature, heart rate, blood pressure, and what we call blood vessel tone. So blood vessel tone is that appearance of your smaller blood vessels in your skin. When your blood vessel tone is more dilated, your skin looks more red, your skin looks more swollen. When your blood vessel tone in your skin is more constricted, you get a more paled, mottled type of appearance of your hands and feet. It's also remarkably responsible for the perception of pain and the appreciation of pain. And then it's also responsible for sweating and drooling, as well as hormone release, growth hormone, thyroid hormone, adrenal hormones. There are other regions also critically important that regulate autonomic input or output, excuse me. The substantia nigra, where all of the neurons for dopamine live. And this, as you can see, heart rate, blood pressure, blood vessel tone, and also reward. So motivation, reward, and voluntary movement. and the raphe nuclei for serotonin, where mood vomiting is a critical center for vomiting with serotonin, and the medulla at the base of the brain, heart rate, breathing, sneezing, and vomiting. So what happens when the balance of the parasympathetic and sympathetic nervous systems become disrupted? Well, this is actually something that my colleagues and I looked at. So Ann Berg, Dr. Deborah Gabler-Spira, and I published a paper almost 2 years ago now looking at autonomic dysfunction and a cohort of children with developmental and epileptic encephalopathies. And this was done through a parent survey using a established autonomic symptom scale. And we looked at 18 different symptoms across 6 body domains. And these are those domains. And in the other, we had things like episodes of pain, sleep disruption, everything that's not classically thought of as autonomic, but is clearly under autonomic influence. And what we found is that symptoms of autonomic dysfunction were present in 81% of the subjects in the paper. And unfortunately for these children, impairment in one functional domain was seen in at least 90% of subjects. So clinically, what do we see? What do I see? What do you as parents and or physicians and healthcare professionals see when this balance clinically presents? So what we're going to talk about next is what happens when the sympathetic nervous system is unimpeded and highly, highly disruptive and overtakes this parasympathetic's ability to counteract it. And this is what's called paroxysmal sympathetic hyperactivity, or PSH. And PSH has been known for many decades in the world of neurology, neurosurgery, and rehabilitation medicine. It was first described decades ago after or as a result of brain injury, also seen in after stroke sometimes, but we now know that it can occur in developmental epileptic encephalopathies. We now have criteria for being able to diagnose this in children. So the paper that I cite at the bottom here is looking at how to quantify and describe this entity. And what we see clinically in children and teenagers who have PSH is you will see a sudden onset of increase in temperature, heart rate, respiratory rate. You'll see flushing, drooling, agitation, and often abnormal body posturing, which is known as dystonia. Understandably, this is often mistaken for seizure because in seizure, you can have many of these same features. You can have a surge of autonomic output. You can have abnormal body posturing. The biggest thing that you see in PSH, however, that you don't see with seizure is the expression and experience of pain and crying as if, as a result of pain. Unlike seizure, these episodes can last multiple hours and then self-resolve, whereas a seizure that goes on longer than multiple minutes does not self-resolve. And critically, we know that in patients who have PSH, the EEG is normal during the events. So I'm going to show you 2 events of the same individual. This individual has a different DEE than a GRIN-related disorder, but that's because I have permission to share these. In working with the AV crew, it does not appear that you'll be able to hear the sound of the videos, so I want you to pay attention to the little girl's face and her expression, facial expression, and the expression of emotion on her face as the video plays, since you will not be able to hear her. So what you can clearly see is this little girl is in excruciating pain. You will also notice how red her whole body is compared to the diaper that she is wearing. And you'll see as the episode progresses, she gets more and more red, okay? And you will see her unusual posturing, the flexion of her arms at the elbows, the flexion of the fingers of her left hand. And if you appreciate her toes, especially on her left foot, um, as well as her toes are curled under her feet, okay? And that is all dystonia. This little girl had had these episodes for quite some time before I met her. Her episodes became so severe and profound that she actually fractured her femur as a result of these events. And that is when my epilepsy colleagues realized that there was something else going on here and got me involved. And this is the same girl after coming into my care and having events that are now much more mild in nature. You can now appreciate the abnormal movements a little bit better. If you look at her toes, they are very clearly curled under her feet. And you'll see the jerkiness of her arms, but her expression of pain is greatly reduced compared to what you see in the first video. And she does not become anywhere near as reddish or orange as the pajamas that she is wearing. And that is how treatment can improve these events. Okay, so we know that when it comes to paroxysmal sympathetic hyperactivity, no matter the cause, whether it be from having a DEE or having a brain injury, that you cannot abort these events when they occur. Because these events are of autonomic origin, specifically, they arise from dysfunction within the hypothalamus. And as such, they tend to occur at a set schedule. Remember, I told you that the hypothalamus is responsible for circadian rhythm and sleep-wake cycles. As a result of that, these events typically occur at set times during the day. So what you have to do is you have to prevent these events because you cannot abort them. When we think about PSH, one of the biggest things is environmental triggers that can, or environmental or patient triggers that can cause events to occur. If the room is hot, it's more likely for this to occur, so cooling the room. Making a low stimulation environment, turning the lights down low, making the room nice and quiet. Working critically, and this is the first step that I take when I meet anybody who has a PSH, is fixing whatever may be dysfunctional about their sleep-wake cycles. And then very aggressive bowel and bladder control. Urinary retention, constipation will trigger PSH events without hesitation. And then evaluating for sources of pain. The little girl that I showed you, even without her events, was having significant dystonia day in, day out. And part of how we got her events to be so much more mild was controlling her baseline dystonia, so that whenever she had her events were starting from a point where she was much more comfortable and not having painful dystonia, hence the reason that her events were so much more mild in that second video. There is precious little that has ever been shown in any sort of controlled trial to effectively treat PSH events. When I use medications to treat PSH, which is in just about every person that I've ever encountered with this entity, I use medications that decrease autonomic output. So I use medications that either decrease the release of dopamine or decrease the release of norepinephrine. You'll see very much if you read the adult literature about PSH and some of the rehabilitation medicine literature, there's a great deal of use of opiate agents. We do not use those in the pediatric population. We use non-opiate medications to treat pain. And as I said earlier, using medications to treat the underlying dystonia that's frequently present at baseline in these patients. So why might patients with GRI disorders have PSH episodes? I'm looking through the discussions and the other presentations. You've heard a lot about the NMDA receptors and how they affect things like epilepsy and things like behavior. And there is a great deal of literature that has shown that the role of NMDA receptors, which are greatly influenced by the GRI genes, play a role in autonomic function. Okay. So as I mentioned first, the biggest area in terms of impact is the hypothalamus. Is there any evidence that GRI disorders may impact the way the hypothalamus functions? In fact, there are. There are numerous papers that talk about glutamate receptors and hypothalamus function. Participation of NMDA receptors in the lateral hypothalamus plays a role in inducing gastric erosion, where your stomach acid eats through the surface of the stomach. Alpha-2, which is one of the noradrenergic receptors, couples to NMDA receptors in the hypothalamus to cause sustained sympathetic vasomotor activity, right? So what does that mean in common parlance? So sympathetic vasomotor activity is that output, that high output of the sympathetic system that causes increased heart rate, blood pressure. So there's a direct link showing that alpha-2 noradrenergic receptors, which can be controlled by using medications to decrease noradrenergic firing, works directly with the NMDA receptor to cause increased sympathetic output. And then the last paper looking at glutamate receptors that induce neuronal hyperexcitability in the hypothalamus and lead to high blood pressure, right? So there is great evidence to say that NMDA receptors directly affecting the hypothalamus are contributing to the experience of PSH. When it comes to sleep, NMDA receptors in the lateral preoptic hypothalamus are essential for the maintenance of REM and non-REM sleep. And glutamate will block the serotonin phase of sleep through the NMDA receptors. So more evidence that NMDA directly and negatively can impact sleep-wake cycles. So there's a huge opportunity here in the world of the GRI and GRIN disorders. What is the neurophysiology of the hypothalamus in all of these rodent and translational models of GRI disorders? What's the neurophysiology of the hypothalamus? What's the neuroanatomy of the hypothalamus in these preclinical models? What about other symptoms in GRI disorders? So, talked about sympathetic output, talked about sleep-wake. You can't directly connect, I can't directly connect the experiences of hypotonia, movement disorders, developmental delay, autism, or even epilepsy directly to the hypothalamus. So many months ago, I started to ponder, is this a downstream effect of NMDA receptor dysfunction? Maybe this is a problem of neurotransmitter disruption. And from the US site, CureGRIN, actually the North American, because it's actually based in Canada, where I am now, when you look at the most common symptoms of GRIN disorders, you'll see developmental delay, intellectual disability, hypotonia, constipation, limited verbal communication, and then things that we've already talked about, dystonia, sleep disorders, autism. And as I've gone to and learned much more about this collection of disorders, there's a direct connection with known entities that are also neurogenetic in nature, but not involving NMDA related genes. So when there's a whole group of disorders that are abnormalities of biogenic amine metabolism. So dopamine, serotonin, norepinephrine metabolism. And the symptoms of these disorders, where your body does not make enough dopamine and norepinephrine, have hypotonia, epilepsy, dysautonomia, GI dysfunction, movement disorders, what's called oculogyrate crisis, where your eyes get stuck in your head and you cannot move them, sleep disturbance, irritability, intellectual disability, and this is well known. This paper was published now 8 years ago and showed that this is the clinical presentation of patients who have disruption in their body's abilities to make dopamine and serotonin. Or sorry, dopamine and norepinephrine, excuse me. And that's because dopamine is responsible for motor control, attention, focus, learning, and autonomic control. Norepinephrine is directly responsible for alertness, arousal, autonomic control, and that fight or flight response. Epinephrine, pupil dilatation, blood sugar control, autonomic control, and then serotonin, mood, thinking, learning, pain. All of the symptoms that we've talked about related to these neurotransmitters. So why might GRIN disorders resemble the symptoms of neurotransmitter disorders? Well, this is a very classic diagram now from one of the best neuroanatomy books in the United States and Canada, called Neuroanatomy Through Clinical Cases by Dr. Hal Blumenfeld, who's at Yale. And this is a very simple diagram of the cortex in gray, projecting down to the basal ganglia in blue, and then connecting to the thalamus in orange, and then back up. And the cortex to the basal ganglia to the thalamus, it's a loop, okay? And what you're seeing in this picture here is the normal type of function, where you see glutamate, which you all know from having learned about GRI and GRIN disorders, sending signals directly to where my primary job lives in the basal ganglia. And you see things like dopamine, okay, and GABA, the main inhibitory neurotransmitter in the brain. And from a model standpoint, we know that when you disrupt dopamine, say in Parkinson's disease, you end up with abnormal movements, cognitive dysfunction, autonomic dysfunction by not making enough dopamine. If you lesion or have destruction of or degeneration of the indirect pathway portion of the caudate nucleus, you get a disease called Huntington. Huntington disease is characterized by profound abnormal movements, profound psychiatric disturbance, and a great deal of autonomic dysfunction. Another inborn error of metabolism, succinic semialdehyde dehydrogenase deficiency, or SSADH, because saying the first one is too long, where you don't make enough GABA, you end up with autism and epilepsy and hypotonia and seizures and movement disorders. When you disrupt glutamate from having a mutation in one of the GRI-related genes, what does it do to the basal ganglia? How does it affect the neurotransmission and neurochemistry? So another great opportunity for those of you who are listening, who are basic scientists in studying this family of disorders. What is the neurophysiology of the basal ganglia in the GRI mice? What does the neuroanatomy look like? Is there a disruption of the normal anatomic structures as a result of the mutations? And very challenging to do in mice, but very easy to do in humans, is direct analysis of neurotransmitters. So in the United States, we have the ability to assess the levels of dopamine, serotonin, and norepinephrine metabolites in patients and get direct information about any deficiencies, and are able to then treat those deficiencies with commercially available medications to control symptoms. So from my closing thoughts, autonomic dysfunction, as I hope I've been able to demonstrate, is a large part of the GRI disorders phenotype. The potential contribution of the hypothalamus to these symptoms is a tremendous area for exploration. And the potential contribution of altered downstream neurotransmitter disruption is a great opportunity for exploration. And with that, my talk is at an end.